Welcome to Med Decode. Today we're jumping straight into a challenging but really essential deep dive. Our mission is to synthesize some of the very newest high-impact research on adolescent and young adult health. This is data that just landed, really, straight from JAMA Pediatrics.
Yeah, we've got a pretty unique stack of sources today. They highlight two key things, I think. First, just how much precision we need to really understand young people's experiences.
Right.
And second, the alarming speed at which these adult diseases are actually consuming the health of this generation.
Yeah.
We have some pretty definitive figures showing exactly how much of that chronic disease burden is now preventable.
Right. So we're moving across quite a spectrum here. We'll be synthesizing sources that, range from the subtle art of asking young people about identity to the hard metabolic data showing, frankly, startling rates of chronic illness in the 12 to 25 group. And we'll finish up looking at shifts in how pharmaceutical companies are marketing certain drugs.
It gives you a pretty complete picture, I'd say, of the youth public health landscape in 2025. It really demands both, a nuanced view of individual experience and an urgent response to these population-level health crises.
Okay, let's try and unpack this complexity, starting with that issue of precise measurement. Because before we even get to physical health, one source really highlights a basic challenge in public health research. How do you actually collect reliable data on something so personal, so complex as gender identity?
Right. This study by Nagata and colleagues, it focused specifically on early adolescence, and it raised this really important question about, language and measurement validity. They basically showed that how a researcher asks the question profoundly changes the data you get back, which, seems obvious, but the implications are huge if you want to develop inclusive policies. You have to measure accurately first.
So if you ask a really simple, direct question like, are you transgender? You might get just a yes-no answer, basically. But the research found that when they used more nuanced questions, things measuring felt gender or using a gender spectrum approach, the results look totally different.
Exactly. And the key detail here, this is crucial for researchers, I think, is that those gender spectrum type questions, I got the widest distribution of responses. This complex layering happened even among kids who'd previously just said no to the simple, are you transgender question.
Wow, okay, that is huge. It means relying on just that binary measurement, it fundamentally misunderstands the population, doesn't it? You're not just missing a few outliers, you could be missing this whole group of youth whose gender experience is complex, even if they don't use one specific label like transgender.
Precisely. And the policy implication is massive. If public health officials only use those simple measures, they're going to fundamentally underestimate the size and the needs of the gender-diverse youth population. That could lead to, a huge misallocation of resources, mental health support, education, even physical health guidance. It just underscores the absolute need for these multidimensional measurements if we want public health strategies that are actually inclusive and effective.
Okay, that sets the stage really well for the complexity in our next segment. Sometimes measurement is complex because identity is complex. Other times the data is complex just because the crisis itself is so alarming. And this is where it gets really interesting and, frankly, quite sobering. We've got this big cross-sectional study by Chetty et al. Looking at U.S. youth ages 12 to 25, focused specifically on obesity-related conditions, or ORCs.
Yeah, this study is a major piece of work. What's particularly powerful about it is the focus on the population attributable fraction, or PAF. That's a concept everyone listening should probably know about.
Let's take a second on PAF then, because that sounds like the key to the policy implications here. We're not just counting how many people are sick, are we?
No, exactly. We're calculating causation. Think of PAF as the sort of definitive blame metric. It calculates the proportion, the percentage, of all disease cases in a population that are directly caused by one specific exposure. In this case, that exposure is being overweight or obese. It essentially tells policymakers, if you tackle just this one risk factor, here's how much disease burden you could potentially eliminate.
Okay, so if the PAF for, say, high blood pressure due to obesity is 30%, that means if you somehow got rid of obesity in that group, 30% of all the high blood pressure cases would just disappear.
That's the idea behind the calculation, yes. Now let's look at the sheer prevalence first. Just how common are these conditions among young people defined as having obesity? And remember, that's BMI above the 95th percentile for teens, or a BMI over 30 for young adults.
Okay, lay it on us. What's the most common condition they're seeing?
It's liver steatosis, basically fat deposits in the liver, often called fatty liver disease. And historically, this was something you mainly saw in middle-aged adults, often linked to heavy drinking. But now, in adolescents, teens, With obesity, the prevalence was a staggering 65.6%.
Whoa, 65% of obese teens.
Yes. And for young adults, 18 to 25 with obesity, it climbed even higher, 75.5%.
3 out of every 4 obese young adults, with a condition that can lead to cirrhosis, liver failure, maybe even needing a transplant down the line. That sounds less like, a minor lifestyle thing and more like a ticking time bomb for our future healthcare system.
It really does. And the systemic risks, the vascular risks, are just as concerning. Hypertension, high blood pressure prevalence was approaching 40% in obese adolescents. We're talking about conditions that speed up damage to arteries, heart disease, decades before they really should show up.
Okay, so that's the prevalence. Now let's hit those PAF shockers, the policy leverage points. How many of these diseases can we actually pin directly on obesity?
Right. This is where the data becomes just unambiguous and really highly actionable for policy. Let's look at type 2 diabetes. In young adults, that 18 to 25 group, a truly shocking 78.9%, nearly 80% of all type 2 diabetes cases in that group were attributable to obesity.
Almost 4 out of 5 cases.
4 out of 5 cases that could theoretically be prevented if excess weight was addressed.
Okay, nearly 80%. That number seems almost unbelievably high. Is there any chance there's some major confounding factor the researchers couldn't fully account for? Like genetics or socioeconomic status, maybe? Something that might bring that number down a bit in reality.
That's an excellent critical question. And, calculating PAF, the methodology itself, aims to isolate the impact of that one exposure obesity while statistically controlling for known demographic and lifestyle factors as much as possible. Now, no study is absolutely perfect, obviously, but a finding close to 80% tells us pretty clearly that obesity is overwhelmingly the primary driver here. It really shifts the focus from just sort of nuanced risk management to needing direct, aggressive interventions on weight status itself.
And this metabolic mess starts even younger. What about the adolescents, the 12 to 17-year-olds?
Yeah, for liver steatosis in those teens, nearly 50%, 49.6% to be exact, of all cases were caused by obesity. Hypertension in teens, 34.4% of high blood pressure directly caused by obesity. Dyslipidemia, that's cholesterol and triglyceride problems, also exceeded a 30% PAF in adolescents. The picture is just crystal clear. These ORCs aren't some slow, gradual buildup of risk over decades. They are highly concentrated, rapidly developing problems tightly linked to weight status, even in youth.
And what's crucial for you listening to GRASP is that this isn't just about obesity, right? Even being overweight carries significant risk. Overweight meaning BMI between the 85th and 95th percentile for teens.
Absolutely, that's a critical point. Even just being overweight had statistically significant PAFs. Like for liver steatosis, being overweight caused about 13% of those cases in adolescents. So this tells us that, really, population-level efforts need to target the whole spectrum of weight, because the risk of these chronic, lifelong diseases starts climbing well before someone technically crosses that line into clinical obesity.
So if we tie this back to policy, the potential impact of treating and preventing obesity seems massive. It's not just about quality of life for individuals, though that's huge. It's about potentially slashing future health costs for society.
Precisely. The data basically provides a clear mandate for intervention. And the sources suggest that expanding access to all the proven interventions, from behavioral changes, diet counseling, to bariatric surgery where it's appropriate, and importantly, pharmacotherapeutic options like GLP-1 receptor agonists. Expanding access could yield huge public health dividends just by significantly cutting the burden of these ORCs in this vulnerable young population.
Okay, that mention of pharmacotherapy, the GLP-1s and such, brings us neatly to another major trend impacting youth health. That's the use and the marketing of stimulant medications, often prescribed for ADHD. We know prescribing rates have jumped sharply, especially since the disruption of the COVID-19 pandemic.
Yeah, we saw this unprecedented spike in mental health conditions diagnoses, and alongside that, a big increase in the use of stimulants, which naturally created a ripe environment for pharmaceutical marketing efforts. So one source we looked at examined industry marketing payments, specifically for stimulants, between 2021 and 2023. And these payments are things like, free meals, travel, speaking fees given to clinicians.
And what was the key shift in how this research tracked those payments? It wasn't just looking at doctors anymore, correct?
That's right. This research picked up on a really key structural shift happening in healthcare. Starting in 2021, their analysis specifically included marketing payments made to advanced practice clinicians, or APCs. So that includes nurse practitioners, physician assistants, other non-physician providers. tracking payments to them alongside the traditional payments to physicians.
Okay, why is tracking marketing aimed at APCs suddenly so important?
Well, it just reflects the reality of how healthcare is delivered now. Many state laws have expanded the practice authority for APCs. They have more power to prescribe controlled substances, including Schedule II drugs like many stimulants. So if APCs are becoming more important prescribers, especially in this post-pandemic landscape, then it's logical that pharmaceutical companies would start dedicating more marketing dollars to influencing their prescribing habits too.
Right. The tracking of payments just follows the expansion of prescribing power. If you're a policy analyst looking at this, it tells you exactly where the industry is placing its strategic bets on future prescribing trends. It's not just some minor detail, it's a real indicator of market leverage. Exactly. It shows the market adapting, really in real time, to changes in regulations and practice. And understanding where those marketing dollars are flowing helps researchers gauge potential influence on prescribing, especially for a class of drugs like stimulants, which, let's face it, carries a known risk of misuse and diversion.
Wow. Well, we have covered a huge amount of ground today, running all the way from the complex, nuanced reality of measuring something as internal as gender identity, through the shock of that hard causative data showing obesity is directly responsible for a massive chunk of serious chronic diseases in young people. And then finally, looking at how the pharmaceutical industry is adapting its marketing to target new groups of prescribers. Yeah, it definitely raises an important question, I think, for you, the listener, to consider. When we look at youth health data now, we really have to recognize that these issues we once maybe nightly put in boxes, minor issues or adult-only problems or things easy to measure, they're all rapidly merging, becoming one complex, urgent crisis. The increasing complexity of measurement, whether it's identity or disease burden, and the sheer urgency of needing metabolic intervention, it all points towards needing a really comprehensive, coordinated, and probably expensive public health response.
Couldn't have summed up the challenge better myself. Thank you for joining us on this deep dive into your sources today. We'll catch you next time.
And that's a wrap on this episode of MedDecode. I really appreciate you joining me today. If something we talked about sparked your interest, or if there's a medical term that's been bugging you, let me know in the comments. And if you enjoyed this, be a pal and share it with a friend. We'll catch you on the next one.